Hello, so today we'll be attempting some radiology cases just before the class. So here it goes. Revision, so there are 10 images, report the findings and review. Oh, this is tiny. How do I remove this part? Never mind. I'll move it to another screen. But then you can't see it. What about present it? Yeah. Okay. So maybe full screen as well. Okay. So case one. Case 1, a 75-year-old Katie Joel. This is the date of birth, 1st of January 1940, I guess. Is brought in wheelchair to your consultation room at HSI with right-sided chest pain and dry cough for the past 2 weeks, worsening from last 2 days. She is an ex-smoker, a hypertensive, and a diabetic. Last visit to a GP, she has been added on tapsilazapine 2.5 mg per day for her hypertension. You clinically examined her and found that there is decreased air entry on the right lung with a dull note on percussion. After discussing with your consultant, Mr. Lee, you order a chest x-ray for her. Please note down your findings and impression. So today we're gonna do chest x-ray interpretation. So this looks like a PA x-ray, although there should be a label telling us that. Because we want to identify whether this x-ray belongs to the patient and look at the date and time of the x-ray. And then you want to look at the quality. Quality, there's a mnemonic RIP. R stands for rotation. Doesn't look rotated. There's the spine. Is right in between the clavicles. Inspiration looks adequate. How many anterior ribs? 1, 2, 3, 4, 5, 6. Between 6 and 7 anterior rib crossing the mid part of the diaphragm. Adequate inspiration. Penetration looks alright. I can see some bone and soft tissue and air. All looks good. So quality is good. Exposure is okay. I can see the costophrenic angle here. So next, go systematically. I have a mnemonic ABCDE. A stands for airway. Check the trachea. So the trachea looks central here. No, I'm not sure what's going on here. Should be normal. I'm not sure. B stands for breathing or lung fields. In lung fields, you can see that there's opacity in the right, middle, and lower zones. It's how do you say, homogeneous opacity. There is no meniscus sign, so I'm not very sure if this is a pleural effusion. However, if you correlate clinically, there's reduced air entry in the right lung and dull on percussion. So probably this is not air, it's either liquid or solid. Most likely liquid because of how homogeneous it is. If it's solid, then there's a liver here, there are bowels that can come up. However, there are no bowel gases here, so I'm thinking more of pleural effusion in this case. You can see pulmonary vascular markings are normal. Okay, so B is done. C for the cardiac. So the heart is slightly displaced to the left side. Either that or she has cardiomegaly, but I think it's displaced rather than cardiomegaly. There's an aortic notch there. Doesn't seem to be any mediastinal widening. D stands for could be cardiomegaly. I can't really tell because this side is totally blocked. D stands for diaphragm. I can see the left costophrenic angle. The diaphragm doesn't look particularly smooth. There seems to be some fibrosis over here. However, it could be normal given her age. I can't see the right hemidiaphragm at all. And E is everything else. Let's look at the bones. No bone abnormalities, no foreign bodies. Soft tissue is the breast tissue. Other than that, I don't see any other abnormalities. In conclusion, there is this a fracture here? I'm not sure. Never mind. In conclusion, there is a there is homogeneous opacity in the right, middle, and lower zones of the lung, and impression would be pleural effusion. Okay, should I write this down? Yes, I should. Shouldn't I? Yes, I should. So, do I copy it? Nah, it's just redundancy. So, alright. Case 2, a 16-year-old male patient, Mr. Murali, born on 1st of January, 16-year-old only, 1999. Came to the emergency department with complaints of shortness of breath and chest pain, which started 1 day ago. The shortness of breath was mild in severity, made worse by exertion, relieved by rest, associated with pleuritic chest pain. left-sided, 5 to 6 out of 10, sharp in nature. He denied any similar symptoms in the past. He also denied any use of illicit drug like cocaine or any history of trauma. He did not have any past medical history or past surgical history. He had no family history of premature CAD. What's CAD? Coronary artery disease or asthma. He did not smoke or drink alcohol. He was on no prescription medications and he has participated in sports without any difficulty. On auscultation, there were no breath sounds on the left side with hyperresonance or percussion, no other relevant clinical information. After consultation with Dr. Rabiato, the ED consultant, you order a chest x-ray. So, looks like a pneumothorax and pulmonary collapse. The whole of the right lung is collapsed and withdrew away from the chest wall to form one small lung here. It's previously well until 1 day ago. It's very acute. Let's interpret the chest x-ray. So first, is this the right patient? At least 2 or 3 identifiers. The date of the x-ray, the time of the x-ray, then the quality of the x-ray, rotation. The x-ray looks rotated. Which direction is it rotated? It's rotated to the right, isn't it? It's rotated to the right. Inspiration 1, 2, 3, 4, 5, 6, 7. Inspiration is adequate. Penetration is adequate. Exposure is inadequate. I can't really see the costophrenic angle over here. I don't know what view of the x-ray is this. Is this AP or PA? Is it lying or standing? Okay. Then we go to ABCDE. So A stands for airway. The trachea looks like it's deviated to the right. However, the x-ray is rotated to the right, so I can't really tell if there's any deviation. Probably not. I don't know. Trachea cannot be assessed due to rotation. In B, it's breathing the lungs. Feels over here looks slightly darker than the rest of the lung. Over here you can see lots of lung parenchyma. Looks quite hazy, but if you compare here, it's totally nothing here. There's no lung tissue here. So breathing, there is absence of lung parenchymal markings. How do you see? Opacity. Absence of lung markings on the left side. I think that's clear enough. C is the cardiac. The heart looks normal. No mediastinal widening. D is the diaphragm. I can see the costophrenic angle, however on the left side is not fully visualized. E is everything else. No fractures, no soft tissue abnormalities. Oops. No soft tissue abnormalities. No foreign bodies. So my impression is a pneumothorax. Not sure if it's tension or not because I can't. Let me see. If it's rotated to the right, then the trachea will look like it's on the right. It might even be deviated to the left, but it's shown as deviated to the right because of the rotation. However, the trachea is even is in line with the spinous process. So I would say it is still deviated to the right. Trachea is deviated to the right. It's tension pneumothorax. Yes, if air comes in, it will push, right? Yes, if air comes in, it will push. So my impression is tension pneumothorax with total left lung collapse. Left-sided tension pneumothorax, total left lung collapse. Needs an emergency aspiration, lung aspiration. In the second intercostal space and mid-clavicular line. But he has been like this for 1 day. It's quite a strong check then. Okay. Do I have time to write? Yeah, I do, right? Okay, let's do this. Can I just copy this over and then edit based on what is different? Penetration, good inspiration, adequate rotation. Airway, trachea. Breathing. My impression is I'm not sure if it's tension. Tension pneumothorax, you wouldn't be there for 1 day. It's better to be hyper vigilant than not vigilant enough, right? Okay. Case 3. Mr. Sulaiman is a 63-year-old gentleman Born on 1st January, they all have the same birthdays. 1952, 63 years old, who has been under your care for a variety of medical problems: hypertension, diabetes mellitus, osteoarthritis, acute myocardial infarction during the past 5 years. Today he presents in the office with shortness of breath, which has been progressive over the past 5 days. He has, however, experienced episodes of shortness of breath during the past 4 months, especially when exerting himself. He fatigues easily and has lost all my energy to do anything. He generally sleeps with 2, sometimes 3 pillows. Sounds like heart failure. He has not experienced chest pain, leg pain, or fainting spells. Examination reveals an undernourished man who appears depressed. His breathing is labored and his lips have a blue tinge. Seems his sinus. Vital signs: blood pressure is on the lower end, 98/82, and the right arm, heart rate 110 is high, respiratory rate of 26 is high, temperature 98 Fahrenheit. How much is that in degrees Celsius? I can look for it here. 98 was it? .6, so it's normal temperature. Examination of the lungs revealed dullness to percussion in both bases, with decreased excursion of the diaphragms. Dullness to percussion in both bases. And decreased excursion. What's excursion? Short journey or trip. The deviation from regular activity or course. Sideward movement. I guess that's decreased expansion. Decreased excursion of the diaphragms. Coarse rhonchi and moist inspiratory crackles are heard when the patient is sitting upright. There is pitting edema of both lower extremities. The patient is hospitalized. Your consultant, Dr. Deepak, asks for a chest x-ray. Sounds like he has underlying heart failure for the past 4 months, and in the past 5 days he got worse. Let's look at the x-ray. Oh. Where's the x-ray? Oh, yeah. Okay, so here's the x-ray. Okay, first make sure it's the right x-ray, the right patient, the right date, the right time, and then the view. This is, it's written here is PA view. So okay, is it erect or lying? Looks like PA has to be done erect, right? Okay, PA erect. The quality in terms of rotation, it doesn't seem rotated. Inspiration 1 2 3 4 5 6 adequate. Penetrations adequate, but the exposure is inadequate, as I cannot see the apex of the lungs and I cannot see the clavicles clearly as well. Okay, so now we go to the quality. Now we done quality, we go to ABCDE. A is the airway trachea. Looks like it's slightly deviated to the right, just slightly. Breathing, there is patchy consolidation of the middle and lower lung, bilateral lung fields. Cardiac, the heart appears as more than half of the width of the thorax, indicating possible cardiomegaly. Mediastinum does not look enlarged. Diaphragms, the costophrenic angles can be seen, albeit not very clearly because of the patchy consolidation. and everything else. There is some foreign bodies seen, probably ECG leads or something. There does not seem to be any bony or soft tissue abnormalities. What's wrong with the rib here and here? Okay, my impression is that this is a pulmonary edema with cardiomegaly. Is there a infection? Probably not. The temperature is normal. What is causing the acute exacerbation of his heart failure? I don't know. Okay, never mind. I'll just write. Oh, the date and time is here. It's taken in 2015. This is outdated. This is wrong X-ray. Okay, never mind. History. I'll just copy and paste again. I have enough time. Right. Nutrition, good, inadequate. ABCDE, Airway Check, yeah. Deviated to the right. Breathing, Epson. Cardiomegaly. Diaphragm. Impression. Okay, next question. Mr. Padman Ravindran, 21-year-old, stage 3 medical student, born 1994, seeking medical attention at HIS for harsh productive cough for 3 days. It started about 2 days after attending clinics at the same hospital. He now has continuous cough with thick yellowish sputum, sounds like an infection, no hemoptysis. There is also right-sided chest pain, fever with chills, malaise, loss of appetite associated with the cough. No other relevant past family history, unknown past family or social history. On examination, vital signs are as follows: blood pressure 152, apical heart rate of 112, and regular respiratory rate of 24, and somewhat labored. Temperature 102. I'm guessing this is fever, right? 38, yeah. Fever. Auscultation reveals bronchial breath sounds, rhonchi, and late inspiratory crackles. In the area of the right mid anterior and right mid lateral and right lower lung fields. The remainder of the lung fields is clear percussion and auscultation. The heart reveals no significant abnormality. Your consultant Dr. Deepak asks for a chest X-ray. Please order one. Please order one. You know what? You already have one. Am I supposed to order chest X-ray when there's already an X-ray here? Am I supposed to interpret this? I'll just interpret this. Okay. So make sure it's the correct patient, date and time of the X-ray, and the view of the X-ray is PA erect. Quality wise, there is slight rotation to the left side. Inspiration is adequate, penetration is okay, exposure is okay. The airway trachea is central. There is opacity, and the right mid opacity in the right lower zone, and there is perihilar opacities. I'm not sure what it is. The heart is normal size. Diaphragm, the right costophrenic angle is obscured. Left is seen clearly. Mediastinum is not enlarged. And no bony soft tissue abnormalities or any foreign bodies. My impression is a lower respiratory tract infection, also known as a pneumonia. Not sure what's causing the pneumonia. Oh well. Okay, I'll just go through all first and write them down, yeah? Because I might not have enough time. I only have 10 minutes until class starts. 21 years old, Mr. Ivan Singh, 1994, brought to the ETD. Is this the same person? No, this is Padman Ravindra. This is Ivan Singh. It's brought to the ETD HIS by ambulance. After an alleged hit-and-run accident. On arrival to ETD, his GCS is 14 out of 5. He was stabilized, primary survey done, and noted chest spring positive. Fast scan at ETD was negative. After discussing with your senior consultant, Mr. Lee, you plan to order a chest radiograph. An oral consent is obtained after discussion with his parents. SGCS is 14 out of 15. Okay. So what's this for? You have now filled the form, obtained an oral consent from the patient after explaining to him the need for a chest x-ray at this moment. The patient walks to the radiology department and gets a chest x-ray done. The radiographer sends you an information once the chest x-ray film has been uploaded to the system and ready for viewing. Now proceed to view the chest x-ray. So this is after accident, right? Fast is for stroke, so they screen for stroke at the emergency trauma department. Negative. No other symptoms. It's just chest spring positive. What does that mean? Is that good or bad? Chest spring. broken ribs. There's no respiratory problems here. Okay, but on the chest x-ray you can see obviously there are some fractures here. So let's look at it systematically, identify whether it's the correct patient, date and time, type of x-ray. This is a portable, so probably an AP. Then look for ABCDE. Trachea is, the quality of the x-ray. So the rotation, not rotated, inspiration adequate, adequate, right? 1 2 3 4 5 6. Yeah, inspiration adequate, penetration is good, exposure is good. Then look for ABCDE. Trachea is central. Lung fills looks normal. Cardiac cannot be assessed due to it is a AP view. What is this here? Seems to be some soft tissue here and here as well. Could be hematoma from the external. You see if you see a patient, you might be able to know that. The heart is not fully visualized. Diaphragms, I can see air under the left diaphragm. Not sure if it's the bowel. Could be perforation of the abdomen, of the bowel. Could be bowel perforation. E is everything else. So this looks like a soft tissue abnormality here. Could be hematoma here as well. The bones, you can see that there is a fracture of the, I don't know which rib is this. 1 2 3 4 5. Is it? I think so. Fracture of the 5th, 6th, 7th, and 8th ribs of the right side. And no foreign bodies. So my impression is rib fracture with some soft tissue abnormalities. Not sure what is it. Alright, I've got 5 minutes left. Spotter, note down your findings. There is patchy consolidation on both sides. Impression, I'm just gonna guess at this point, pneumocystis. I might have seen something like this before. This one, spotter, note down your findings. And see here, left perihilar mass. You can see that there is the vertebra is unusually opaque, unusually white and bright here, so it could be too much calcification of the bone. Not sure what it could be. It's sarcoidosis or something. No, I don't know. This one, spotter, note down your findings. It's very blur. I can see there is a right upper, there's a cavitating mass on the right upper zone with surrounding fibrosis. There's left perihilar opacities as well. Big mess, about 7-8 centimeters in width. My impression, it could be TB, the cavitating mass. What else? Klebsiella can have a cavitating. What else can have cavitating mass? Staph aureus, is it? Oops, what's going on? Can be a cancer as well. This one looks like a pediatric chest x-ray. It's miliary. Looks like miliary TB, however. In pediatrics, there might be another condition which may look like this. I don't know. Don't know what's going on here. You tell me. Is this the last one? Okay. There are perihilar masses bilaterally. What could be causing this? And surrounding fibrosis as well. No lung markings here. What's going on? But the quality is real bad. Could be malignancy. Could be lymph adenopathy. What's causing this? I don't know. Could be sarcoidosis as well, though it's rare. It's a common exam thing. Oh, the clavicles doesn't look right here. Bones don't look right here either. Alright, class is starting soon. That's all, folks. Hope it helped.